surgery at UCL, consultant surgeon at Whittington, secretary of BOMS, and several more. I'll stop there, let you carry on. One-Anastomosis Gastric Bypass.
Thank you very much, Vinod, for the kind introduction. Waiting for my slides. So I'm obviously going to talk of strategies of reflux after one-anastomosis gastric bypass. Yeah, there's it, managing reflux after one-anastomosis gastric bypass. Thank you, Sanjay and the team, for this kind invitation. It's always a pleasure to be here, and thank you all for coming in large numbers. Supposed to move. Okay, these are my disclosures, nothing related to the talk. The only thing is my majority of the work is OAGB. More than 50% of my cases are OAGB. So please see the talk in relation to that. So first of all, does reflux happen or ulcer happen after OAGB? And I think there's always a debate that no, it never happens, and controversy around it. But I think yes, it happens after OAGB. Same as it happens after any other bariatric surgery, I would say. If you look at all the systematic reviews at low BMI, high BMI, first 13,000 patients published in literature, we found that the OAGB post-operative GERD was around mean of 2.08%, and same way marginal ulcer was around 2.7%. So I would say that is acceptable rate. What happens in a revisional scenario setting as well? So obviously this is the first 1100 patients of conversion of either bands or sleeve to OAGB, and even in that scenario, we found that post-operative GERD was a mean of around 3.29% and marginal ulcer rate was around 2.44%. We have literally just published this 15 days ago with Amit and Anuja, and I can see them here. Most recent and probably the first systematic review and meta-analysis looking at 5 years and beyond results of OAGB, and even in that scenario, nearly 20,000 patients, 32 studies from 14 countries, mean follow-up of 6.7 years, and it shows that yes, it can happen de novo in 4% of patients, and marginal ulcers can happen in around 2% of patients. The good thing is in those scenarios, it's quite straightforward. Convert that to Roux-en by gastric bypass, and you are kind of sorted. This is the worst scenario. And why are we worried about reflux and ulcers and things in the first place anyway? I think we all thought that there are going to be lots of OG cancers after this operation. So we went around the world and actually asked people to submit their data. We found from 25 countries that no, it's not that there are a lot of cancers in the pouch or junctions after OAGB, and that's what we found. So we followed it up obviously with a systematic review as well. 324 cases reported till now. We only have 4 cancers reported in either the pouch or the OG junction. I have just been informed of one more cancer for Portugal, so I'll try to publish that as well. Before going on to strategies, like Sandeep just touched as well, I think prevention obviously is better than cure. I won't go in detail, but I think the key is choose your patient wisely. Don't do them in patients with Barrett's or serious esophagitis or 5 centimeter hiatus hernias or stuff. Sort out your H. pylori, NSAIDs, smokings and all those issues before you start doing them. Obviously, focus on technical issues or like avoid short pouches and stuff. And like I said, avoid in smokers and things to begin with. I think I can see Sufi in audience, even vaping is not good for those cohort of patients. And not in detail, but yes, your operation at the end should look something like this, nice lie of your afferent and efferent loops and long pouch so that you don't have reflux. Won't go in much detail in investigations. Like Sandeep mentioned, a good history, endoscopy, CT scans, pH manometry. If you actually interestingly look at the consensus statements, they don't really say that everybody should have. Yes, be pragmatic if it is available, and if you need it, do it. The main reason I like to put this slide is for laparoscopy. Even if your patient has an undiagnosed reflux and you struggle to manage him, stick a laparoscope. It could just be a kink or a twist or a hernia or something which is manifesting as reflux. So that's probably the main point in this slide. Now coming to treatments. So treatment for GERD after OAGB, we published this algorithm few years ago. Obviously go through the history, majority of them can be solved conservative management, PPI. So we tend to give 6 months post-operative prophylaxis for all our patients anyway, but in that scenario, restart them. If there is try to investigate the cause on OGD and a CT scan obviously, and if there is a stricture at the junction, say try and do an endoscopic dilatation, and like I mentioned, in a worse scenario, put a laparoscope as well. Conservative, continue for 6 months to probably even a year, depending on how bad the reflux and the symptoms are. And like I touched on, in a worse scenario, you can very straightforwardly convert it to Roux-en-Y, because by this time your patient would have lost weight, and it's just a matter of JJ and dividing you don't need to do anything with the pouch unless needed. So that was reflux. Then comes marginal ulcer treatment. Again, I think majority of that, this is the IFSO consensus guidelines from Hamburg we published in 2018 or so, where we all agreed that managing a marginal ulcer is nothing different in OAGB compared to Roux-en-Y. So kind of follow the same algorithm for this cohort of patients. Going into further, there is a book we published, I think 2016 or so. There is a nice algorithm out there as well. In these scenarios, add sucralfate to this patient's cohort as well. And again, I think rest of them follows. If the ulcer heals, probably the only additional thing you would do here is maybe continue your PPI for lifelong in this cohort of patients. Just recently, ASMB has published similar algorithms. So I just wanted to show that there is something similar from ASMBS as well, where they probably have said something similar like scans and smoking and all in the algorithm as well. Roux-en-Y conversion, that probably is the last resort, rarely needed, but worth knowing. There are 3 different ways of converting them to Roux-en-Y, and I think that's why I wanted to show the slide. So one is the Lonrod technique. You simply detach it and that's it, sorted. Next step is where if your GJ anastomosis is either strictured or problematic, in that scenario you can separate the whole, resect the whole anastomosis and do that. But what you can also do is, if you are worried about weight loss, either less or more, you can also manipulate your limb length accordingly. So that's one advantage of doing that. Scenario C is, imagine if it's a strictured horrible GJ anastomosis. In that scenario, you obviously have to resect your whole anastomosis and redo the whole thing. So these are the 3 easy ways of doing Roux-en-Y conversion when needed. Bronze anastomosis, if you don't want to do convert to Roux-en-Y anastomosis, limited evidence out there. I think there is one from David Carrigan series from UK as well. So straightforward, around 60 or 70 centimeter distal to the GJ, a simple JJ firing and you are sorted. Again, there has been a lot of debate about should it be 30, 50, 70. I think it does make sense that if you're doing it for reflux, do it around 70 because you don't want the bile to reach up there in the pouch again. Marginal ulcer, straightforward. I think perforation, patient stable, just like your other perforations, an Omentel patch would do the trick. This is something what is not reported, but we hear anecdotal reports from people, endoscopic interventions. So for Roux-en-Y gastric bypass, what they are doing is they are closing the ulcer bed with a stitch. You could do similar for OAGB as well. Another one, just wanted to highlight, along with closing the ulcer bed, they have also put a covered stent in it and they have produced good result as well. So I think endoscopy skills should, I think all surgeons should know it. This is something very innovative, endoscopic conversion of a bypass, a reversal. What they do is they put an EUS guided gastrogastric stent, create a fistula in a stent, and then endoscopically close the GJ, and that means you have reversed the whole anastomosis bypass as well. Obviously, there are a lot of books out there. I can see a few juniors here. So before you start doing any procedure, please go through these books and read and talk maybe to some people around and have a few mentors and watch videos before starting it. Sanjay mentioned this book earlier in the day. We have now a separate section on OAGB in this cohort of patients as well. We also have an OAGB MGB masterclass for people in Europe in 4 centers in the country as well. So to conclude, my friends, I think yes, GERD can happen and marginal ulcers can happen, but majority of them can be managed conservatively. I think lifestyle changes and dietitians and all input normally sorts the scenario. And like I highlighted, there are endoscopic ways, surgical, either a corrective surgery or a conversion surgery can be there, and I think PPI normally sorts things out and avoid risk factors. And on that note, I would like to invite you for 2 main conferences in May. Malaga, the IFSORU European Chapter Conference, and obviously our own BOMS conference in June in London itself. So please note these dates in your diary. Thank you very much.